Markowitz. I am the editor of the Idaho Business Review, and I'd like to welcome you to the third breakfast series installment for this year. It is called Dr. Islaudin Solve Idaho's Medical Crisis. We're so glad that you're starting your day with us. What a fantastic note. We have a feeling that this was going to be a hot topic, and you were right. We'll wind up in an excellent panel for today's discussion, which I will introduce you all momentarily. But first, the breakfast series would not be possible without the support of our 26 program sponsors. I'd like to recognize our series presenting sponsor, Holly Troxel. Holly Troxel is Idaho and Inland Northwest premier business and litigation law firm. I'd also like to thank our supporting sponsor, Bank of America, St. Duke's Health Plan, and Grove Hotel. Thank you for your support. We've had some very serious conversations leading up to this project, but I apologize in advance for this. I've always wanted to ask this question. Is there a doctor in the house? I'm sorry, you're so moving. Today's discussion covers something that states across the nation have been struggling for years. Idaho, as many of you know, has been ranked 50th in the U.S. in terms of healthcare staffing. To talk that out to the providers here is simply preaching to a choir. That's bad news for the state's ever-growing population as well. Good news is that Idaho's providers, educational institutions, and other stakeholders have been working diligently to solve the problem. And at times it can seem like tireless, thankless work, much like the healthcare industry. But in our according to IBR, we have found those involved in the problem solving are dedicated to ensuring the healthcare staffing ills. And that's enough out of me, so let's get started with this. Our panelists today from the far end toward the B is Dr. Ted Epperly, President and CEO of Full Circle Health, Tammy Fife, Chief Operating Officer, Chief Information Officer of Terry Randy Health Services, Susie Keller, CEO of Idaho Medical Association, Christopher Hall, Dr. Christopher Hall, Chief Clinical Officer of St. Alphonsus Health System and President of St. Alphonsus Medical Group, and Dr. Jim Souza, Senior Vice President and Chief Physician Executive of St. Luke's Health System. And for more information on them, you can read that in the co-grants to fires. Now, I'd like to try to go over to Trudy Hansen-Bowser, partner at Holly Troxel, and today's moderator. Trudy?
If it's not working, no one has ever asked me to speak up, so I think we'll be okay. Good morning. The turnout is wonderful, and the topic is incredible. It affects everyone. It affects patients, it affects businesses, it affects the physicians, the hospitals, the clinics, all of us. And so now, I think we have to get a hand to Mark for putting together this amazing panel that's going to talk to us about how they're working tirelessly to solve this problem. First, as Lark said, we are 50. How many states out of it? In the pro rata physician rotations. The last state, how is it that we got here? I think that's where we'll start off. And Dr. Epperly, how did we get to this point where we are so behind?
Thank you, Trudy, and good morning to you all. This could be an hour's off by itself, but I'll give you about a 3 to 4 minute overview of why we find ourselves here. As Trudy mentioned, we're 50th out of 50 in terms of the number of physicians per capita. We're about 17, or we have about 3,500 physicians in the state of Idaho, but that leaves us about 1,700 physicians short. We're 1,400 physicians short of the national average. And every one of our counties is a mobile health shortage area. 43 out of 44 are physician shortage areas. So Idaho has a significant issue it's dealing with. Now, having said that, it's taken decades for us to get here. So let me unpack quickly 5 major reasons that Idaho finds itself in this situation. It's a bit of a perfect storm. First, we've had an underinvestment in healthcare workforce training. The data and research is really clear that you'll provide and produce physicians, nurses, dentists if you train them close to where they're going to remain. Data shows that about 75% will stay within about 100 to 200 mile radius of where they do training. So we had an underinvestment in the number of training programs. That's very true on the physician side. This isn't a medical school issue, it's a residency program issue. Maybe years after medical schools, you do 3 to 5 to 7 years of additional training. If those residency programs are there, then you'll start to populate the area. Number 2, we have geographic challenges. 40% of our patients live in rural or frontier areas. It is hard to recruit to rural and frontier areas. There's a professional isolation that happens. There's issues within families, spouses finding jobs, good education for kids. There are issues in terms of limited specialty support in rural areas and a lot of call-related issues. So the challenges of geography. There have been demographic shifts happening in Idaho. A lot of people moving in, a lot of retired people moving, a lot of stress on the system. Idaho is a flyover state. So if you don't know about the graphic scenic beauty of Idaho, it's hard to have that on your list if you're from the East Coast. And lastly, I just want to have a special call out to the population growth in Idaho. If you look at data from this year's US Census Bureau report, Idaho is the 2nd fastest state growing in the United States, next to only South Carolina. And over the last 5 years, it's the 1st and largest growing state in the United States. So you put all of this together in terms of ranking 50th out of 50, having not enough physician and other allied health professionals. You have a massive influx of people that have happened over the last decade. You all have witnessed this, you've all seen the traffic from this, and it results in this. We have more patients, more chronic disease, increased demand for healthcare, not enough providers. And I'm going to leave you with one last point, and we'll move on to other questions, because I want you to chew on this. You would think because of this that our healthcare outcomes would also be last, or pixel last. We rank, according to the Commonwealth Fund, 19th in the United States for healthcare outcomes. And I think there's a couple factors here, and I'll end with this. It's our outdoor living, it's our outdoor orientation. We have less smoking here. We have a lot of family support systems here in Idaho. We have a good quality of life. We have less chronic disease. So all of that is good, but if we don't get on top of this problem now, with this influx of people, the next 5, 10, 15, 20 years will make us a new Appalachia in regards to our healthcare system and the help to our people. With that, Trudy, I'll stop.
Thank you. Dr. Epperly, the first time I met him, he was an expert witness in a trial that I was having defending a physician, and he testified on behalf of the physician. And you probably guess how the physician did in that trial. Okay, for all of you, beyond the clinics and the hospitals, how does it affect other industries, this shortage? What is going on? Why should businesses be concerned about this? And I'll start with you, Dr. Souza.
It's an economic challenge to the entire state. Speaking to a group of business leaders, Susie Keller could have unpacked this in more detail, Uh, Healthcare contributes more than $2 billion to the Idaho economy, but speaking with physicians, I think the number in your study, it's $1.3 million roughly that each position adds to the economy and wages and jobs and support services. So, we just think about the 90 or so OBGYNs were lost in the last 3 years, and it's about $125 million from hit to the Idaho economy. Of course, if you're a business leader or people need health care, they need access, when they need it, they need it to be good. So, hey, what's all this?
Okay. And Dr. Hall?
Actually, you want to go next, Susan? You go next.
Thank you. I'll first hit on the economic impact of physicians that Dr. Souza mentioned. And it is true, physicians do have a tremendous economic impact and benefit to our communities to the tune of $1.34 million per physician. In addition, Idaho physicians support over 12 and a quarter jobs per physician in the community. So that's directly and indirectly, so throughout the healthcare sector. So that's also pretty important. And they also contribute to our tax base to the tune of about $46,000 per physician in local and state tax revenue that's generated as well. But aside from the economic factors, I believe every Idaho citizen and every Idaho business should be very concerned about the fact that we have lost over a third of our OBGYN physicians in the last couple of years. And that's just OBGYNs that have been able to be tracked. When companies are trying to recruit workers and retain their workers in Idaho, I don't think it's unreasonable to want to ensure healthcare access for half the population of our state. So I just feel like we should all be very, very concerned about that. And those physicians left for a variety of reasons, but primarily due to our strict abortion ban. And that does have an impact. Our state laws do have an impact on our healthcare workforce.
Thank you. Susie, do you want to chime in here? Tammy?
I think really the only thing I would add is just access. If you, as an employer, if your employees don't have access to primary care, then they're going to lose more time from work. It's going to impact kind of your bottom line as business leaders. So I think just really having access, especially in like the rural community, when we don't even have an option for primary care, then you're taking more time off, or you're not actually going at all. And so I think that's kind of the other aspect of it.
I just add a couple points. We're all connected, right? So we're in an ecosystem. And so when you have one part of the ecosystem not functioning fully, in this case, then it has ripple effects within community stability. And so what we see is absenteeism more. We see presenteeism more. People are less healthy. That has an impact, a ripple effect on performance at work and job production. So it's all connected. One sector down, it's going to hurt all the businesses in a community, especially in a small community.
All from a physician perspective, what about the importance of support staff?
Yeah, it's already been referenced before, but it's amazing how if you take one single position, directly probably work with at least 3 to 5 people, they really, nowadays, physicians can't do their job. Probably Dr. Susan and I now let 12 people that help take care of us. But if you look at really the position, if you go see like a typical primary care office, they're gonna have 3 to 5 people helping do it. And a lot of our really complex, highly complex teams in care, so think like our trauma team at St. Alphonsus, the team that really takes care of you is probably a couple of dozen people, and they have to be really expert in every single thing they do. And so it's really, really important that team kind of approach. So we have not only help recruit those people, sometimes we have to be involved in training those people. So it can be everybody from a pharmacy tech to a pharmacist to a medical technologist, somebody in the lab, blood bank. And if you think there's nothing more important in the health in a hospital that we forget about every day until you get the call. It's like blood bank technology and really making sure that you're really, really smart people that can help make sure that what's one of us happened in an accident, that you have the blood products you need. And that's like 1/1000th of our team members. And so every single person is really, really important. I'm a peds hospitalist. I knew my bacon was saved by OB nurses. And if you don't think I did bring them candy every single time I was on duty, I brought them something. So, they could make the life a lot easier for me and for mom not have a baby. And I'm never on anybody's birth plan. And so making sure that it's a team approach, the confidence when I walk into the room, the baby's going to do really well. And so it's super important. We can't just focus on recruiting physicians. It is going to be a challenge recruiting obstetricians into this community, but really making sure that we're looking at every single member of the team. So when we're recruiting physicians and advanced practice practitioners, they're going to walk into a team setting that knocks it out of the park and makes their life a lot easier.
Thank you. And Tammy, what have you found are the positions in Idaho's healthcare that are typically understaffed as part of the field?
I think we've talked about several of them, and I guess Woodman, Berman, you all probably had different responses based on kind of the gaps that you're trying to fill. And I think what was mentioned earlier is that we need to think about healthcare broader than just kind of the doctor. It includes, behavioral health, it includes dental, it includes supportive services, allied health professionals like MAs and like DAs. And there's a difference in hard to fill roles, kind of in recruitment, and hard to keep roles. There's, the roles that have the highest turnover are those NAs and those DAs and those support staff, but really has an impact on the entire care team. So it really is a balance of recruitment and retention. I would say also that if we look at the rural areas and what we've actually got to talk about, and Dr. Efferly said, but just adding some geography, when we try to recruit care teams and physicians for those rural areas, I think you talked about isolation and some other things, but they have to basically drive this pretty autonomously. So we're looking for experienced providers, and it's really hard to get those experienced providers that want to actually live in those communities rather than commute. And if you think about areas like up north, Coeur d'Alene, Sandpoint, McCall, people might want to live there, but there's a housing issue. How are you going to provide housing for those support staff and those other members of the care team? There are health systems that I know that have to either provide housing for some sort of stipend. So when you think about what are the hardest to fill, it really kind of depends on the need and the need of the community.
Thank you. And then the end we get into it sounds like there are two issues. One, recruitment. How are we going to get the positions here? And then how are we going to keep them here? So Dr. Epperly kind of took, I don't think he took it from the bill and they will come, but he's basically, train here and they will stay. So let's start with getting more physicians in Idaho and how best to do that. Now, maybe Jim, why don't we start, what's the process for, say, for maybe recruiting physicians international? Is there something, is that ongoing and successful?
Yeah, so the first thing to know about international medical graduates is that for most of them, their training will not meet ACG&E criteria to allow them to have privileges in practice in the United States. So for most of them, they're actually seeking a residency or fellowship position, and the way they do that is through the J1 visa process. Once they finish their training, then a couple of things can happen. The J1 visa will require them to go back to their home country for 2 years. they can apply for a waiver, which usually occurs through the H-1B visa program. And I think that waiver is 3 years. You can extend it for another 3 years. So maybe I'll think about this in terms of benefits and risks. The benefit of looking for international medical graduates is there's a large pool of highly trained, very experienced people who, when you compare and contrast them to a resident, for example, these docs are ready to take on larger amounts of patient care work and panels and so on and so forth. And they're highly motivated to come to the United States, bring their families, and establish a practice. The risk is for someone bringing them along is the uncertainty and the growing size of the investment. So the uncertainty comes from, well, will they be granted an H-1B waiver? Or will they go back to their home country? If they get a waiver, will they stay with, whichever organization is supporting and sponsoring, or will they go somewhere else? And then the size of the risk has been growing, as you're probably aware of the kind of new federal fees, which are being contested, like $100,000 per. So that the investment in a single human individual, highly trained, competent, ready to jump in, runs you around $130,000 to $150,000 with an unclear outcome at the end of it. The other pathway that's gaining some traction, at least in terms of interest, and was someone in the audience who does a lot of work on this, Scott Smith, is the alternative pathway for international medical grads, which would allow them to come to the U.S. and it's essentially like an apprenticeship underneath a licensed physician without doing the residency or fellowship. The challenge with that is it doesn't create a pathway to board certification. And just speaking about my system, like you can't get privileges in my system unless you're really certified. But very rarely the waiver is granted for that. So we're not currently pursuing any of those candidates. I think we're only pursuing one J1 cardiologist total time. So it's a risk-relevant conversation.
So presently, that may not be the answer to the issue.
I agree, but it could be if we had a national approach.
And then, Susie, the Idaho Medical Association, I think sometimes always don't give it credit it deserves, because I think that IMA is working incredibly diligently to help solve this problem. And can you tell us a little bit about the educational pipeline for physicians, what that looks like in Idaho, what the Medical Association is doing?
Sure, and thank you for that, Trudy. And I very much appreciate that my colleagues here are mentioning the other members of the healthcare team. And obviously the IMA is physician-centric because we are a physician organization. So that is our focus, and our organization has been involved. And I think it's helpful for folks to understand this educational pipeline and all the pieces and parts and how we can impact it and improve it. And Dr. Everly did a great job of laying that out, but it starts with K-12 and going to a four-year institution and getting a bachelor's degree, and then applying, going to medical school, and that is an area where Idaho has a very robust set of opportunities for training medical students. So we were training close to 300 medical students per year. So be graduating 300 medical students per year through the institutions that are here in Idaho. So the well-being mental education program from the University of Washington, another through the University of Utah, and then of course our Idaho College of Osteopathic Medicine. And then, as Dr. Epperly said, the next phase to determine where a physician is going to practice in their specialty is residency training. And right now, per year, we have about 90 residency slots. So you can see this part of the pipeline for medical education is very robust, and we have a little bit of a challenge here with residency training. And so that's where the IMA has really been putting our efforts along with many, many other organizations to get state funding from the Idaho legislature to be able to grow those opportunities. And this is one area that we have been quite successful with the Idaho legislature. We're very grateful to them for recognizing the importance. So we've been able to double the number of residents and programs that we have. But another thing that's important to recognize, as Dr. McCurley said, those folks, when they train here, they stay here. So we may rank last for the number of physicians per population ratio, but we rank in the top 5 states in the country for retaining the residents that we train here that actually come and stay here. So that's something we should be really proud of and something we should continue to grow on. But after they train, how do we keep them here? How do we attract others here? And that's where another piece of the pipeline is really important, that recruitment and retention piece, and a big part of that is loan repayment. These folks are coming out of training with huge debt levels. I sit as chair of the Rural Physician Incentive Program Board. That's Idaho's loan repayment program for physicians. And we see applicants who have $200,000, $300,000 worth of educational debt as they are starting out in their practices. And so the loan repayment piece is really important. And then finally, what's the practice environment, that end of the pipeline? How do we keep and attract people here? And the practice environment has to do with reimbursement. It has to do with administrative burden. It has to do with what are our state's laws and what are opportunities for a physician spouse who perhaps wants to have a career. Physicians value education. Do we have a good K-12 education system for those families? So all of those parts of the pipeline are very important, and so IMA has been trying to influence and impact those particular areas where we need more work.
And Christopher, what efforts does St. Alphonsus take during this onboarding process to make sure that the candidates are a good fit? You know, that whole idea of retention, once you can lure them in, how do you make sure they're a good fit?
Yeah, I think it's really important. It starts with what Dr. Suso is referencing. It's a little bit about your national graduates and a lot about what Susie was saying, but the first thing it starts is with recruiting. And so we have to get past the headlines. The headlines nationally aren't always going to help us. I mean, we're all here because we want to be here, and I'm like clearly the most incomer up here by like decades. And so finding people that came here for the reasons I came here. So first thing, to discuss those headlines and really making sure there's some really positive things about Idaho. So we have actually a really fair medical board. Some medical boards nationally are pretty activist. So they have a lot of non-physicians now that are on their medical boards. And so Idaho is a pretty friendly place. It's a pretty fair place. I also think for malpractice, the pre-litigation process is outstanding, how that's handled. So we try to really accentuate the positives about living here, more than just it's a great place to live, but you also have to work here. And so really making sure that like physicians we recruit obstetricians or gynecologists, that our health systems will stand behind them and making sure that we're going to stand lockstep with them. So they want to be able to come practice here and not be afraid of prosecution. So those are some of the important things. I'll just cut right down to it. Dr. Susan and I probably both get calls where we get called in to help with special recruiting people. I vary tactically, and I'm outing like my secret. Dr. Souza will probably steal it. I was very commonly, I spend a lot of my times up on the trails up above Boise. I will FaceTime them from the trail. So I'll be like, I'll look at their CP, they like hiking, they like trail running, they like whatever, and I'm like, I have a dog. My dog is so not smart. She's gorgeous. And so I will just have, hey, the dog, and I'm like, oh yeah, sorry. And literally, one thing we can do in Boise, you cannot do in other places. You could be hiking or trail running on those trails and you take call. And so now it's trying to push it with the traffic, 40, 45, 30 minutes. But I've done that now 3 or 4 times in 6 months, and I can win 2 out of those 3. And so you just go in.
Well, and I was tell you, one of the best recruits I ever got, this was like 15 years ago. He's a critical care about, I don't say his name. He called me and I left him a voice message that said, sorry I couldn't pick up your call. I was making sourdough bread. He's saved that message for 15 years and he occasionally plays it.
The other thing we do with recruiting, it has to do with a lot of the folks to the right. So looking for Idaho kids, so people that have Idaho connection that grew up here. So one of the medical students that come through here, they graduated from one of our head schools, keeping track of them in our mental Rolodexes. Dr. Mark Nasser is back in the back. Your daughter just taught a fantastic slot for dermatology, which is hard to get. Everybody should give Dr. Nasser. You don't think that all of us recognize, like, I know a kid, local connection, went to our medical school at ICOM, could be done with dermatology in 4 years, maybe partnered with somebody in the healthcare industry, like keep track of those and make sure we recruit them back to Idaho. That's probably the first thing we try to do. The next is we try to look for people that have values that align with the values, so community focus, family focus, want to spend time. We ask our physicians at San Alfonso, they work really hard. So we want to have a really busy, thriving practice, but at the same time then have a work-life balance. And so when we can get on off call, making sure that they can enjoy the community, they want to do the things here. Honestly, I screened on Collier the other day. The person had outstanding physicians, like 3 ex-wives and a sailboat from San Diego. I was like, yeah, it's a hard nut. But I'm not picking on the ex-wives for the sailboats, like it's one of those. We can't pay that person enough to come to Boise, and they're just not gonna fit in. And I'm pretty sure the sailboat they're talking to in San Diego is gonna fit on the Boise River, I just don't see. So really making sure that we find people with local connections. We're filling our hospitalist slots. We already have multiple, like I think it's 3 or 4 ICON grads are just now coming back to Boise to be able to practice hospitalist medicine. They're actually calling us ahead of time practically. I'm finishing next year. I want to come back and practice at St. Alphonsus. I want to come back and practice in Nampa. And so trying to keep track of it and making sure we have roles and jobs for that. Thank you.
And Dr. Epperly, so I think it was 2012 you authored the book on the healthcare crisis. So he's kind of had in tune with this for a while now, but he's Idaho's graduate medical education coordinator and author of the state's 10-year GME plan to strengthen and expand healthcare in Idaho. So tell us, how's it working?
It's working well. Ken Susie alluded to this. We doubled the number of programs in the state of Idaho over the last 9 years. We almost tripled the number of residents in training. This train to remain concept is critical. We can get them here. We can get them to fall in love with Idaho. In our residency programs, we have mandatory rural rotations. So 1 month each year, they've got to be out in one of 40 different rural communities. That helps in terms of auditioning to be in that practice. It helps those clinicians see that they would like this resident to be one of their future partners. It helps them fall in love with rural Idaho. So you have to have mechanisms where we're increasing the amount of training in Idaho. We can bring them in instead of exporting them out, which is what we're doing right now with the majority of medical schools. So if we import them in through the GME programs, train them in Idaho. That's where the magic happens.
Susie alluded to this. Despite us ranking 50th in terms of retention out of residency, we're in the top 5. We're the second fastest growing state in the United States in terms of GME residency training per capita. So there are lots of signs of optimism here. It's an internal structural issue in Idaho. We have some headwinds. Susie alluded to that with some of the legislative laws and policies. But I'm convinced if we can get people to Idaho, and we've discussed this earlier, we can get them to fall in love with Idaho because it has a lot going for it if we can get them here.
Thank you. And Tammy, as a federally qualified health secretary, right, what are workforce challenges that are specific to Terry riding?
Well, I think that some of our challenges are actually common across the table. As you can tell, that we basically all compete for the same pool in a lot of areas. And so as a safety net provider, we're not always able to compete against larger health systems. And so we become kind of a training ground for new health, professionals, which isn't a bad thing because we do a lot of things like with the residency rotations, which would keep the providers here. We've also built our own residency programs internally for pharmacy, for dental. We have apprenticeship programs for MAs, for DAs, and so really it's taken advantage of the fact that we are kind of at Burton Institute, kind of not as much as GME, but we're actually training kind of that next generation of workforce, and which is especially important in like the rural areas because we want to support the communities and make sure that we're providing jobs in those communities, and you're not always going to find somebody that has an experience, and so we can actually grow them into those positions, and they're going to stay. And so that's so the challenges we face is more probably are having to work with new providers and just kind of the time that it takes to actually train them to be able to work in an environment, especially with our patient population. It's a little bit more complex, and so it's not easy for a brand new PA or MP to actually work in that environment.
And Jim, you talked about the financial hurdles that these new graduates face. Does your organization offset any of the costs in any way for potential physicians moving into Idaho?
Yes, and I think probably all or most of our systems are doing this. The average medical student leaves with $233,000 in debt. The median is $215,000. So in recruiting, that cost, because I don't think either Chris or I's organizations are going to change their mission. We're going to keep recruiting physicians. We need to keep recruiting physicians. So you understand that to get them here, we need to mitigate that. So yeah, we offer relocation and loan forgiveness, and I'll just say it's a fraction of that number, and it usually comes with some kind of a commitment, of a few years. And for the highly sought after specialist with a particularly large amount of debt, sometimes we'll extend the years in order to also expand the pool. I wanted to say one additional thing that's adjacent in terms of what we have here in Idaho to solve this problem. And Chris mentioned it when referencing our medical societies, and it's really useful to have a perspective like this as an insider, as recently an outsider, can remind us, like, you guys got a good thing going. You have medical society and IMA. For us who are wearing red here and been here a long time, it's like you don't know what you got because it hasn't bled. our known society is not, and that we've been strong advocates for this. And in part, this, I'm going to call out something that is only a risk. I think it hasn't come to fruition yet because of the efforts of people up here on this, maybe particularly Ted and Susie, and that risk is a design problem. You business folks probably know when you have a problem with a process, one of the first lessons is go to the Gemba, right? Go to the front line where all the knowledge exists and none of the power exists. Because otherwise you're going to design something dumb. I think in the realm of GME, our state leadership grabbed on very early to deep involvement of the people who are involved in medical education, who know about medical education, who know how to solve this problem. 2 years ago, we came real close to just shoot ourselves in the foot type of an error with undergraduate medical education. Now, we overcame that not because our state leadership created a poll and pulled from the Gemba, but because the Gemba pounded on the door and said, "You got to wake up here." So, we overcame that risk. It is a risk, though, that we just need to have, I think, as part of this conversation. Everybody up here on this panel, everybody who's involved in medical education, we won't quit banging on the door if we're not invited in, and doors open and we'll pull them. But that's our design for this.
And Susie, I know you've kind of touched on this, but I think this is, what tools does the Idaho Medical Association use to make the case for state investment in physician training programs and getting the physicians here?
I'm going to touch on the financial piece in a moment, but first I'm just going to say it's about relationships and trying to form connections with those decision makers and legislators and remind them that they care about having healthcare access in the communities that they represent, and that they know in their communities a graduate of one of Idaho's medical education and residency programs. And that really makes a difference for most of them. Some of them are happy to get their primary care from the local dairy vet, but I know this from experience. My husband is a dairy vet. But there are folks, that's not gonna matter. But for the most of them, they care about this and they want this for their communities. And the other reason they want it is because of what we've touched on before with the economic benefits. And I do want to say that the IMA partnered with the Idaho Coalition for Safe Healthcare to commission this study, and it was released in December of 2025. And we utilized and partnered with economists from the University of Idaho, and I think that was a really great tool to be able to show Idaho legislators this is Idaho information from an Idaho institution, and it really shows this tremendous return on investment. So we asked the legislature to fund GME positions at about $60,000 per resident per year, okay? When that physician comes back and practices in Idaho, they are contributing $1.3 million in general economic activity per year. That's a huge ROI. And so for those that don't care about having healthcare in the community, sometimes a fiscal argument works, and I think that's an important tool for us to have, and remind ourselves that physicians not only take care of our people in our communities, but they contribute to the economy as well.
Thank you. Okay, so we're recruiting all these physicians and healthcare providers. Now, how do we keep them? How do we prevent, let's say, the burnout that I think that so many of the providers are experiencing? So let's start with, for all of you, any of you found that AI is helping your providers get a little bit more time with taking care of some administrative tasks or making their lives just a little bit better?
Yeah, I am a drop a line under that I've started to use. I actually believe from my industry that the robots may return humanity to practice of a profession. I can't believe I'm saying that because I'm generally a skeptic about AI for humanity, but I'm a wild supporter in terms of healthcare. I think all of us now are using ambient listening. So it's large language model, AI, that is facilitating the visit so that when I'm in clinic, instead of, doing this, it's eyes on vacation, my phone through the listening device is listening. I still use my license to authorize the documentation and what happened there. But what that does, probably the mechanism, let me say this about ambient listening, at least in our system, is the first technological solution we have brought to healthcare where, from the physician perspective, it could come fast enough. The medical staff create a pull, like get it to me faster, that started to pilot it a few years ago. And probably the mechanism of that is cognitive load. It reduces cognitive load. Yes, we demonstrated inside our system, it's decreased pajama time, so documenting at home, finishing your charts at home. It's improved our accuracy of documentation a little bit. It's been associated with physicians being able to add an extra patient or two, so it's improved efficiency. But what its primary mechanism probably is cognitive load, because when my phone knows, like, it's recorded everything, and I know that, and I know I'm going to be able to come back and reference that in my own time, in my own leisure. That kind of nagging little, voice that I need to finish this, I need to finish that. It's seriously tamped down. There's other opportunities though that go beyond large language model. And I won't be reading this. If you want to ask me about this, maybe after the panel, grab me. I mean, we're co-developing and we have my innovation clinic, something called an LCD, a large clinical decision model, that is starting to play with almost bringing to life this concept of AI being a co-pilot on my shoulder. So not only listening and recording for the verbal content of what happens, but because it knows me, because it knows the patient, it has consumed the entire patient's medical record. It's serving up to me what my most likely next clinical decisions are going to be, so that I use my authorization action with my medical license to bring those to life. But another way of bringing down the cognitive load, which at the end of the day, the reality is there's more people that we have for physicians and UPPs to take care of. They're older, they're sicker, and they're inside the social safety network that is more shared there than ever. So, like, this moment in time kind of needs to be the funeral for our excuses of finding solutions.
Dr. Hall?
Yeah, so St. Alphonsus is affiliated with a much larger health institute, Associated Health, and I'll be honest, like some days that could be a little bit of a challenge. So actually the folks from Michigan were out here a couple weeks ago. It sort of blew them away. They wrote in Boise, and I'm on calls where they have to explain to the Michigan people that the reason why they're investing the most in all of the country paternity health is tracer value. It's because of the growth. One of the other advantages here is they have a much larger bank account than I have. And so they purchased the entire suite of Epic, our electronic medical records AI tools. And so we're implementing them about every 4 to 6 weeks. There's another package. Very similar to what Dr. Souza said. It's really focused on time saving for a whole host of different roles. So physicians, cognitive load, but now we're starting to see tools come in for nursing. There's some new one being launched right now that'll help nurses finish their notes sooner at the end of their shift. Nurses have an incredible documentation burden. They just sit and just click boxes, it seems like. Some of them work so fast at it. And so if we can take that kind of work away from them so they can spend time really thinking about the patient, spending time with the patient, that's huge for us. In about 3 or 4 weeks, actually, I just circled on a calendar on that period. By the way, I'm at Dr. Souza, I'm incredibly low tech outside of this. I was on the AI skeptic side. But a lot of our physicians at the end of a very complicated patient hospital course, you have to write a discharge summary. They can spend 10, 20, 30 minutes summarizing that patient's care before they have to go to another facility or a nursing home. So there'll be a AI tool that'll come on that'll summarize all of that for the physician and allow them to become editors that say, oh yeah, Phil's right, Phil's right, maybe I'll change this. And it really isn't change the way they work. So I think there are some positives on the horizon. Where I'm really excited is to see the ambient listings who go from physicians and advanced practice practitioners, but to nursing, to emergency physicians, to chaplains, to social workers. So really get it into all sorts of different roles because they have is the same documentation burdens. I think we have to be very patient right now, not try to rush it. It's like I'm in the middle recovering from a stress fracture, like being that kind of like patient. If you see me out and I'm kind of cheating right now, but people even I'm like getting back into but you. So really being patient, making sure that we're bringing tools forward that make a lot of sense for physicians. One good thing is we're doing these as a dipping your toe in the water, which is the way I get into the pool. I'm a jump in head first kind of person. Actually, if you've done emergency medicine, none of us jump head first into it. I have to kind of look the other way. But really making sure we try it because there's a few of these tools, they put them out there, they pull them back a little bit and said it's not ready yet, and then give it another go when it's more ready.
I'll just make one quick observation about AI and what I'm hearing from physicians that I speak to that use this. And for all healthcare providers, this is going to be a piece of reducing healthcare provider burnout. These folks touched on that, the amount of time that folks have to spend after the clinic gets closed and they're supposed to be having time with their families. So I think this is a good thing for our physicians, and we may talk a little bit about the burnout, how long, but this is one of the antidotes to that.
I would just add that I think we all agree that it's definitely reducing the burden and the cognitive load. I guess I would caution that we have to be intentional and also mindful about the implementations, because if we do too much and we're going to add additional cognitive burden with somebody else, and it's really kind of that change fatigue. I think the other thing when we talk about workforce, having to recruit IT talent that is specific to the EHRs, this is going to probably increase that some. And so you still need somebody to manage the applications and roll out. And so I think that it's kind of a double-edged sword, is that it's fantastic and it's a game changer, for the providers, but we have to be cautious about how we're actually going to roll out.
Yeah, just a couple of points I'd make. AI is going to be transformative to healthcare, absolutely transformative. We've spent a lot of time talking about the importance of the team here. It's become a critical team member. So we're using it in scribing, messaging, scheduling, diagnosis, treatment, and it's showed us increased outcomes and decreased burnout. What's not to like about that? Now, it has to be watched. It's not perfect. But I can't imagine what it'll be like in 3 years, 5 years, 10 years, 20 years. Think about it, managing and helping us manage populations of people, not individuals, which are really well, but the whole population of people.
I mean, we're just scratching the surface in terms of possibilities here. I just wanted to make one pivot to telehealth. Telehealth's important too. When we talk about rural providers, we don't need to drive miles, hundreds of miles to Boise, Oaktel, or to Lang if we could get telehealth to them in their community. Let's take electrons to them and not miles of gas for them to come. But you need a connection point. So the importance of, again, a primary care physician, nurse practitioner, PA, in rural areas where you can have the node connected. Telehealth's another big deal. We're just kind of scratching surface, I think, with what we could do. Think about the combination of telehealth and AI. I'm telling you, 5 years from now, 10 years from now, we won't even recognize some of the changes that will happen that'll be costing for people.
Just add, having defended healthcare providers for 35 years, it might be an outcome that no one wanted, and then a lawsuit, and inevitably, 9.5 out of 10 times is the documentation bank. There's not the documentation isn't there to support the care that was obviously provided. And so I think this will go a long ways in, assisting the providers in feeling good about not only care, but that documentation that, apparently there seems to be this rule that if it's not documented, it didn't happen. And I keep saying that just can't be true. No, it could still happen, but that is haunted. So I think that this is really a wonderful move in the right direction as far as medical malpractice as well. So with kind of Dr. Eckerle's jump to my next, it's nice we're almost out of time, but a telehealth. I think that's a not remarkable way of delivering care. And Jim, what do you think about telehealth and the St. Luke's system and providing care through telehealth?
It is part of the solution. I agree with Ted. And it's the pandemic has a lot of, Chris and I before this, we're talking about some of the nasty tail of the pandemic and behavioral health, mental health, things like that. But the pandemic, finally, even though you zealots like me that believed in telehealth before it was cool, launched a tele-ICU back in 2013.
Wow.
The pandemic changed that for everybody. And one of the saddest visits that I get would be somebody from McCall driving down snowy Highway 55 in the winter to see me on a piece of real estate where I'm having my clinic, risk their life, burn gas for a 15-minute follow-up visit of why. That's insane in the membrane. There's a better way. And, maybe it's even just managed asynchronously through technology. My charts, communication, which means as a system designer, I need to know how to figure out how to pay the Dodger for that work, because it is work. Managing a patient through iChat messages, not face-to-face, and they maybe don't get paid for it with work hard leaders. But telehealth's a beautiful solution to that type of a simple problem. And then, boy, add in AI to it. I agree with you, Ted. The brave new world is, we're starting to get glimpses of what it might look like, and I'm generally very honest about it.
Well, and even in the hospital, when you have the surgeon in the room and wondering about something, they can bring in the nephrologist up on the screen and talk to them. And absolutely, yeah, I think it really is going to be a game changer. Okay, I think that finishes our time. Thank you so much. But if you do have questions in the audience, our panel would love to answer them.
Now, we know everybody has questions here. There's just too much there to unpack. So raise your hand over to the mic.
Good morning, thank you. I'd be interested in knowing more about the residency pipeline If 90 available spots are available to us now, how does Idaho get more? And to bridge that gap to 1,700, to eke up, where can we win on that?
Yeah, I'll take the first cut. The Rural Health Transformation Corridor, again, $186 million a year for the next 5 years, and Idaho can get out its own way and get this done. $930 million over 5 years will help expand workforce. And so we're looking right now for GME expansion, opportunities, rotation opportunities, all focused rural, to start to build out that pipeline. It's a marvelous 5-year plan. It will start to do that. Right now, and you may be aware of this, I'll stop with this, is that we're having trouble with the governance of how the money gets appropriated. And we're in danger of losing the whole kit and caboodle. If we don't get this straight in the next 6 weeks, it's coming down to the wire here. And so, bless our hearts, we want to do the right thing, that sometimes we have problems getting our own way.
And what money is that, Doctor?
That is from HR 1, the One Big Beautiful Bill. You may remember there was $1 billion per state that would be part of this to help transform rural healthcare. So it's a big package deal if we can get on top of it.
And what happens if we don't?
It goes away, and it goes to other states. So we pay our taxes, United States, and other states are going to reap the benefit.
If I could add to that, up here we had 2 outstanding organizations developing primary care physicians, especially primary care physicians that deliver babies. So hoorah for anybody delivering a baby in this state. So thank you. They're huge partners, and all of our systems are built on primary care. Like, that's the base of all of our systems. So really appreciate that. I'm also super fortunate. We had a really outstanding trauma medical director, Ryan Boats. He's had the vision to bring San Alonso as a level 1 trauma center. So we have, the first time ever, through our organization, surgery residents, 4th-year surgery residents coming. Now they're elective, they're volunteering to come to Boise to do surgeries with us. So we're hoping we can help recruit them in to be part of that team. It sort of shocks me when they had this idea 6 months ago when I heard about it, and I was like, I think we'll get one. We filled every one of our seats this entire year. So that's really fantastic. And then another thing, if you've ever been a physician who has believes or thinks or says they're world class, who hasn't, there's a few of us that doctors that believe that, and I'm like, I think you have delusions of grandeur. But Andre Shushurpet, he's a skull-based neurosurgeon. That guy's pretty amazing. I've seen his work. I've let him operate on my head. I wouldn't flat Boston. Well, my wife's from Boston. It's being lost. But Andre Shushurpet is really amazing. So we have skull-based fellows starting this summer at St. Alphonsus. It's one of those things we're not advertising, but we have people willing. They're I don't know what a skull-based fellowship is. So they're 7, 8, 9 years into training, coming to Boise, Idaho to do surgery with our teams here. And so it's not just our primary care. I'm really fortunate that we have really great primary care organizations, but it's every level of this. And we need to focus on residencies more than just primary care. We need to start looking at other types of specialty type training that we can bring to this area, because that's how they're sacred.
Dr. Finley, I just wanted to follow up more on the comment. We have 6 weeks related to rural healthcare transformation. I'm just wondering, you have a group of business leaders here who have relationships. My question is, what's the information? Who does it need to be delivered to? Because it is significant. We have healthcare systems in our rural who are operating on razor-thin margin right now. We're going to lose them. We'll increase the distance that people will have to travel for care. So again, what's the message? Who is it that it needs to be delivered to?
Yeah, that's great. I'll just give a really short answer here. The Idaho Department of Health and Welfare is the governor's working agency for the point of contact from CMS to get this money. The Idaho has developed a legislative oversight committee of 8 members, 4 senators or representatives, 1 member from the governor's office. It's those 9 deep that need to give final approval to this money. The Idaho Department of Health and Welfare is ready to execute the contracts.
the application forms. It is that committee's governance interface with the Idaho Department of Health and Welfare. Those people can be found online. The Legislative Oversight Committee is the choke point.
Anyone else?
Over there.
This is when my inner Philbonhue comes out.
Thank you all for the information you've given. You talked a lot about support for doctors, helping burnout, all of that, how AI can support. Are there efforts going on with people kind of a little adjacent to the profession, like community health workers who can provide significant support, who become a part of the team, even though they're kind of a little bit outside the healthcare arena?
Yeah, I'll take that. So we have invested in community health workers as part of the care team. We have a pretty large group of them, but I think that it's really thinking about how to reimagine the care team. I mean, we have technology that's going to change the way that we actually practice, but also thinking about how we can reimagine the care team. When we've done, brought in the community health workers to help the population health care coordination, but we've also embedded paramedics within our care team to kind of fill some of the gaps of some of the RN shortages. It kind of gives a higher level of clinical expertise, especially like in things like triage, urgent care. We've started to really lean on our clinical pharmacists to actually be shared visits, not only the medication reconciliation and adherence, but what can they do to help manage some disease states. We actually just got them DEA licensed and certified in medication opioid use treatment, so they can come along those psychiatric providers and actually provide care. So yeah, it's thinking about the care team, I guess, differently and where we can actually expand that.
And what you just surfaced is the concept of care model. When Dr. Epperly talked about, if you want to, he didn't say it this way, that you want to picture the old days of healthcare, walk into one of your primary care offices today and snap a picture, because that will be the old days. It's going to change. The care model has to evolve. There's not enough of us, as I said, to take care of all of the people. So care model, I don't know if that sounds like jargon. It's when the care occurs, who provides it, what they do, how they do it, AI, telehealth, these are going to seriously impact that, and what it creates for the patient. And all of those things are going to change a big part. I agree with Tanner. The care model redesign that we're all thinking about is expansion from physician to still going to be a team captain. But then you think about, and this is a rabbit hole in medical education, how are we training our doctors of the future to be a team captain instead of a lone wolf? Because I was trained in the era of be a lone wolf. You're the accountable person, you're autonomous. Well, in my era, it's like the ship is my ship. There's no staff on the ship. So it's an important discussion point in medical education.
Anyone else? Warren?
Yeah, thank you guys so much for the info that we're talking about today, important stuff. In regard to the team approach, I think that is so vital. I'm a child psychiatrist, but I feel like when you look at our state, we're the only one on the map that doesn't have like a pediatric psychiatry access line. I went to school for this. I really wanted to make sure that was something we had in Idaho. The barriers are like all over the place and they're hard to pin down, but we're working on it. But one of the things with that team approach, and like it can feel like in training, it really was a team approach, and everybody kind of fed in the info. And then I had this kind of crotchety old attending who said, "Yeah, but you're the only one that gets sued." How does that work? How does that mean in the end that matters when it comes down to how the work is actually shared?
Yeah, well, so, we have from Med now, attorney moderating today. I've always said that, I used to say is that young doctors, I was recruiting my male private practice. The reason you have Med now is so you can do the right thing. I would also point out that as you take on the role of team captain, come back to the Spider-Man quote with great power comes great responsibility. That, yes, but the accountability rolls uphill when you're the captain of the team. It always does. It never rolls downhill, or at least it never should. The buck should stop at the top. Now, a clientable team has the best of the position. It's just, I don't know, Chris, what you'd say about it, but I feel like it's our lot in life, and it's why we have a greater responsibility, and that's part of it, is supporting the team.
We are seeing two members getting seated.
If I could just add two quick points. As you guys have heard, it is a team sport.
Primary care in particular is a team sport, from community health workers, nurses, to MAs, nurse practitioners, PAs, to physicians. It is a huge team sport, and that what makes it viable in rural. It can't be the lone wolf out rural. It's got to be a team big step. To the child psychiatrists, we have developed the Child Psychiatry Fellowship System. It's Kempogitao, and we have, in conjunction with the University of Utah, child psychiatrists now training in Idaho for Idaho. So we're making headway. We got a lot of work to do in Idaho to catch up, but we're on the right tracks. And I just want to leave you with one thought, and Jim alluded to this too. We have a lot of reasons for optimism. It's a great state. We're all 19th in healthcare outcomes. It's not like we're 50th, which is wonderful. We got a lot of stuff going for us. Jim alluded, and Chris alluded to the fact that we've got a good medical board. We've got a great medical association, the Idaho Medical Association, the Idaho Hospital Association. The governor's office has been hugely supportive. The legislature, quite frankly, has been very supportive. So we've got a lot of good stuff going here. It's a matter of just pulling it all together, staying focused, and moving forward.
All right, we've got one last question from the audience, because although we could probably keep all day with questions, we're going to give our panelists some leave after this.
Wow, last question. Thank you, panel. This has been really wonderful. My question is, I've been working since retirement with refugee and immigrant physicians that have had lots of experience and are well trained. Some of them maybe not. How do you get them into our system? Because what you heard was that being board certified is kind of a huge barrier. And that's trying to make some sort of a external judgment about, are they qualified and safe enough, basically. Without board certification, you don't get hostile privileges, you don't get favorable malpractice rates, you don't get good reimbursement from the insurance companies. And so I feel like we need some way to experiment in a small number to say, is it okay to not put that barrier there for someone who's excellent, has gone through one of these alternative pathways, and helps to solve our problem. This year, we've crossed the line of over half the states. 27 states now have alternative pathways. We were one of the first. And yet, trying to get these operationalized is really difficult. So just a quick answer to what do you see as possible solutions to that?
I'll take the crack, Tara, Chris, and see how you guys would add in. I think Scott and I were talking before this, and I think your own answer is the right one. Inside of the intense regulatory environment of U.S. healthcare, the intense medical legal landscape of U.S. healthcare. Taking on risk, for one, especially given the size and the financial outlays that I talked about to support that risk. It's like, how do you balance that risk with this potential benefit, which could be huge, but you don't? And I really think it's a national overlay that's required, some alternative pathway to board certification, a truncated period of time of supervision and demonstration of actual skill sets, because I'm with you, Scott, that these trainees could be a substantial part of the solution. They're like more ready to go than some of our best trained but still inexperienced young physicians. They've been there, done that. Some of them have done it in war zones. I mean, you're awesome. How do we make it happen? A national plan would be one, de-risking for us.
Okay.
Thank you, Trudy. The Breakfast Series report was published in the June 19th edition of Dragon Business Review. That's the same day, and today's recorded of it will be available to rewatch at our website, in case you missed anything. Thank you again to our Breakfast Series presenting sponsor, Holly Coxell, and our supporting sponsors, Bank of America, St. Luke's Health Plan, and the Grove Hotel. And if you need assistance with, on June 9th, as we will recognize, you can see on the screen there, our Accomplished Under 40 and Icon Award honorees. That will be next Tuesday at OEC Center. If you'd like information about the 2026 Breakfast Series or other Idaho Business Review updates, please visit our website, idahobusinessreview.com. And that's all we have for you today. Thank you all very much for coming out and good